Good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Review Group. I'll just go through the admin stuff first. This evening's meeting will be live streamed to the public, and a recording will be available on the Council's website within 24 hours. Any remote participants joining via Teams, please use the hands up icon to ask a question or make a comment. Turn your camera and microphone on when speaking and off when finished. Anyone in the chamber, please remember to switch the microphone on when speaking and off when they're finished speaking, and speak directly into the microphone. And please switch off mobile phones or place on silent mode. Okay, go straight into the agenda. Apologies for absence.
Yes, Chair, apologies from Stephanie Power from Health Watch.
And I have an apology from Councillor Fry. Okay. Minutes of the last meeting, 21st November 2023. Play a true and fair record of what happened on that evening. Okay, thank you. Any disclosures of interest?
None that I'm aware of, Chair.
Any urgent business?
Yeah, none, Chair.
References from committees and other bodies?
None, Chair.
Okay, so a couple of things have happened since the last meeting. At the end of November, myself, Councillor Ambia and Councillor Umiali attended the first meeting of the reconstituted BLMK JHOS. The minutes of that meeting are on I believe they are on the Milton Keynes District Council website if you would like to have a look at those. And yesterday I had a meeting with the Corporate Director of Public Wellbeing and Service Director of Public Health to discuss the future direction of these meetings, the structure and the future agendas. If anyone would like to have any input into those discussions or talk about that, we can do that, and we will also can discuss that at the appropriate time at the end of the meeting. Okay, if we start with the first agenda item, the first report, agenda item number 7, primary care access in Luton. Who is giving that report?
Thank you, Chair. Amanda Farrer here, Associate Director, Primary Care Commissioning and Transformation for BLMK, and my colleagues with me tonight, Beth, so I'll allow Beth to come in and introduce herself.
Good evening, everyone. I'm Beth Collins. I'm Head of Integrated Primary Care for BLMK ICB.
So Beth and I are going to do a double act this evening. We're going to take the paper that we provided to you as read, and we're just going to draw out some highlights from the report and also highlight some areas of good practice in terms of access and good news that's happening for Luton. So I'm going to start, and then I'm going to hand over to Beth to provide some further updates, and then of course we'll take questions at the end. So as I'm sure colleagues will have read in the paper that we circulated to you, our practice teams in Luton continue to provide considerable activity, appointment activity, and in the period that we provided in the report for this period last year, the 3 months, and the same correspondence period of the previous year, there was an additional 4.25% increase in appointments, and that's a position we see in Luton and we see across BLMK. Furthermore, Luton provides a good balance of appointments face-to-face, which is important for members of our population. And the Luton figures represent a good utilisation of the practice team. We know that it's not possible to always offer appointments with GPs, and practices are multidisciplinary teams led by GPs. So it's important that we utilise the workforce in the appropriate way to the residents' presenting need. So the data tells a positive story in terms of activity levels. However, alongside that, we do know that a number of our residents continue to have a poor experience when making contact and booking an appointment with their practice. And that's where our transformation work in Luton and across BLMK it is important. And as we've described before to members of this group, we're using the fuller stock take of 2022 and the NHSE Delivery Plan for Recovery and Access to Primary Care, published in May 23, to provide the framework for the transformation that we are doing. Alongside the report that we submitted to you, we set out the practices and their alignment to primary care networks in Luton was Appendix 1. Appendix 2 that we provided with you was a glossary of terms, because when we work with our residents, it's really important that we use consistent language to describe primary care and general practice, so that it supports residents' understanding of how to utilise services. Appendix 3 was what we've referred to as a plan on a page, and this really summarises all of that transformation work that we continue to do to improve our residents' experience of accessing primary care. So if I just summarise for colleagues, our focus of our transformation work is ongoing communication and co-design with residents to support their understanding of primary care and how to navigate primary care and general practice. We're working with our practices to support them to transition to a modern general practice access model, and that will help residents to make contact with their practice using cloud-based telephony, and so that residents know on the day they contact their practice how they will be managed, so that they're not asked to call back a next day or a next day. I've already referenced the improvements that we're making to practice telephony. It's really important that we ensure that patient services are all joined up. All too often we hear poor experiences of residents who are referred by their primary care practitioner to a service in secondary care, and then report that they don't know what is happening, or that they have to retell their story more than once. So the work that we're doing as a system around integrated neighbourhood working aims to reduce that duplication and to improve the experience for our residents. We want to ensure that we use the range of services that are on offer. We know that demand is extremely high for general practice, and whilst we're continuing to see increases in activity, we need to make that sustainable. So it's really important that we support residents to use the range of services that we have on offer, such as community pharmacies for minor illnesses. And it's really important that we open up self-referral routes as well. Not all residents need to see a GP if they require a referral. For instance, for community physiotherapy or podiatry, we can support self-referrals. So that reduces the need for a GP appointment and allows residents to get the service they need potentially more quickly and reduce the number of appointments they'd have to attend. As I've already said, we're really pleased to see the high number of appointments that take place with professionals other than a GP. We've really increased the practice workforce. We've introduced a range of additional roles and new roles to the practice team. And those roles are really valuable members of the team and can really help residents with certain presentations. And we're trying to facilitate sharing good practice between each of our practices in Luton, because this is complex work and it is a huge task to do this transformation. So we're helping our practices to learn from each other so that we can support all to deliver good services to their residents. I will stop there and I'll quickly hand over to Beth, who's going to draw out some of the examples of good practice that we wanted to highlight to you this evening.
Thank you, Amanda. So just three things that are happening or have happened in Luton that are wider areas of access and improving things for residents that we're involved in with primary care. The first one is a day that's coming up on the 27th of January, where we are supporting a Better Health and Wellbeing Day that's taking place in the Central Square in the Mall on that day, where people, as they're passing by doing their shopping, can just stop and have things like their blood pressure or blood sugar checks undertaken, and BMI, some diabetes prevention management advice will be available, weight management and other health prevention initiatives will be there. What we have got in place is a process so that any information that is gathered on that day with the residents' consent will be shared back with their individual GP practice to ensure that appropriate follow-up takes place for anything that is picked up on that day and that's perhaps outside of a normal range and needs a follow-up. There is a piece of work that's being done as well around the vaccination and immunisations, where we're working with partners over the next few months to actually reach out and address specific areas, concerns that we have around access to vaccinations or uptake of vaccinations across Luton in all of the different areas for vaccination, from childhood through to some of the more adult ones, such as seasonal flu, etc. We're going to identify various settings are being identified at the moment that will be easy access for anyone who wants to attend. So some will be in the town centre, perhaps in the Mall, and community venues across Luton will be going to. We're using the opportunity, as well as vaccination, to be delivering some key health messages, smoking cessation advice, etc., and other health promotion issues as we can get through. The third area I'd like to identify is the significant work that's been taking place over the past year across Luton around improving cancer screening rates. This has been recognised nationally, and it's been around improving the outcomes and the experience for people with cancer. There's a lot of work happening across various teams. Community connectors are supporting us to reach those groups that we're finding difficult to reach into, such as the Eastern Europeans, the Black African and Caribbean communities and the South Asian communities. We have got a specific primary care work stream around our cancer that's attended by all PCNs in Luton who have really embraced this work that meets monthly. And the priorities that they're working on at the moment are improving prostate cancer early diagnosis, improving screening uptake generally, standardising urgent suspected cancer referral processes across PCN so it's really clear what's happening and where people are going, and working to increase community awareness around the signs and symptoms of cancer. One of those, particularly the prostate cancer finding, 2 of the PCNs in Luton have already completed their pilot, and as a result of that they found 18 men with prostate cancer who didn't know they had cancer, as there was no obvious signs or symptoms for them. So really good benefits already being shown and impacts on those individuals for that early diagnosis. I'm sure you'll agree that these are really important pieces of work that are wider than just routine access to a GP that were happening. There is a full update on the cancer work going to the Health and Wellbeing Board in February, but just wanted to give you some key highlights this evening. Thank you.
Okay, thank you, Amanda and Beth. Does anyone have any questions? Councillor Nissa?
Thank you, Chair. My question is, you did mention that beside the GP, the other clinical professionals are able to see the patient. So my question is, do we have enough other clinical professionals in place to fill the positions?
Thank you. So I'll take that question. Beth may want to join me in answering as well. As I set out at the start of the report, our practice teams continue to deliver more appointments year on year. However, we know that demand continues to be high. The additional roles reimbursement scheme has allowed us to expand practice teams over the last 5 years with the benefit of that additional investment. I think the assessment of whether that is enough is probably a difficult one to make with the increasing complexity and the rising demand in our population. Our work is to ensure that what goes to practice teams is what needs to go to practice teams, and that we can signpost and navigate our residents to other services other than general practices when it's safe and appropriate to do so. Anything you'd want to add, Beth?
Thank you.
Yeah, just would just add that our PCNs have been really successful in Luton, have managed to recruit a significant number of additional roles, perhaps a better uptake and recruitment than we had seen in other areas. So they've done very well.
Thank you.
Councillor Ambia.
Hello, good evening, and thank you, Chair. I have a question. Your colleague mentioned about self-referral, like for physio and other service. So who's going to vet, like and direct for the appropriate clinician? Is it for physio or GP or nurse? What is the procedure? Wasn't clear about what is the process for vetting for the request?
Now, that's a really thank you for that question. That's a really important question. So the idea is that if we open up self-referral pathways, we need to communicate those to residents so that they understand which services they can take themselves to. So if you've got lower back pain, for example, it may not be the best to go to the GP practice and see a GP. You can go straight to the physio service, but we need to be able to articulate that in a way that's understandable and meaningful to our population. There are other examples of self-referrals as well. So in BLMK, we have a number of services that do provide self-referral. You can go to your GP and be referred, or you can go directly to the service. But I think your point is a really valid one. We've got to be communicating clearly with our residents about what those services offer and when is the right time to use them. Similar to the campaigns that we've done when we've talked about when to use 111 and when to use 999. If a patient did take themselves to a service that accepted self-referrals, that service would undertake a triage and an assessment in the way that any clinical service would do. So it would be the clinician that saw the resident that would then ascertain that they were the right service to treat the patient. And if the patient had self-referred themselves to the wrong service, of course, they would be signposted and supported to find the right service in the right way.
Thank you. If I'm, can I have one more question, please? And also another thing, from my experience, I have seen when patient attend out of our extended service. So when if clinicians advise for any sort of test or any scan, they don't internally follow up from the main GP clinician. They ask patient to call and arrange an appointment. But if patient find very difficult to get an appointment, that's why they ended up to come to extended service clinician. Why the extended clinician, they again advise patient to book an appointment with the GP. My question is, why not extended clinician? They can internally refer to the main GP. Just saying patient came and these things, and patient need to have a further blood test or ultrasound or things. So is there anything you can look into this issue? Because at the moment I can see is extended services, they're not talking each other internally with the main clinician. Thank you.
Thank you. That's a fantastic question, because that is a focus of a lot of the work that we're doing. We know that on occasion when patients use other services, what we refer to in the health service is the episode of care is not completed. So there are occasions where those onward referrals are not managed appropriately, or those booking diagnostics and tests is not done appropriately. Now, on some occasions, there's a good reason that that a resident should go back to the GP, and the GP, as their coordinator of care, should make the appropriate arrangements. But there are a number of examples where it is appropriate for another service to make those onward diagnostic arrangements. So we are working with our general practice teams and our associated services, community services, secondary care, etc., to ensure that where possible, onward arrangements like that are made by the clinician who sees the patient, because it's a poor experience for the resident, and secondly, it utilises practice time that we could avoid utilising and could be used for another resident. So that is a really important piece of work, and we talk about it as improving the interface between all of the services that we commission to make sure that we improve the experience for our residents.
Okay, well, thank you.
Amanda, can I follow up on the self-referrals? Is the self-referral process actually, has that started? Is that working at the moment?
Yeah, so a number of services already accept self-referrals. Nationally, as part of the NHSC delivery plan for recovery and access to primary care, we had to assess ourselves against 7 pathways where self-referral is clinically appropriate, and we provide self-referral in each of those 7 pathways. So the next phase of our work is to make sure that we are really communicating that well to our residents, and actually self-referral exists in Luton and BLMK in far more than just those national 7 pathways. We have a number of services where residents can self-refer, so that's a key part of the communication that we've got to do as part of our transformation plan.
And how's it going so far with the self-referrals?
So numbers are quite low currently, higher in some services where it's been well established for a long time, but some of the services that we've added, the numbers are quite low. So it will take time through that comms campaign and awareness raising for that utilisation to increase in a way that might start to have some impact.
Thank you. I have a question about paragraph 8, the plan plan that sets out 2 central ambitions to tackle the 8 a.m. rush, and for patients to know on the day that they contact their practice how the request will be managed. How is that going? Are we tackling those two issues?
So the NHSC delivery plan for recovery and access to primary care is a 2-year plan. It was launched in May 2023, so it runs until 2025. I always have to check myself when I talk about years, because doesn't time go quickly? So yeah, runs to 2025. So we've asked practices to set out their plans for delivering what's referred to as modern general practice access. All of our practices have now set out their plan about the transformation they're going to undertake and have set dates of when they will achieve that modern general practice access model. And it isn't a single model. Practices will do it in a range of different ways, but they will achieve the ambition of essentially managing today's calls today, is the thing that we are monitoring our practices on. So all of our practices have set a plan and with a date by which they will achieve it.
Okay, so do we know what sort of progress is being made towards those, to fulfilling those plans?
It's quite early days, because the fund, whilst the NHS delivery plan is a 2-year plan, the fund was announced after the May plan was published. So it's quite early days for a number of practices. And as I've said, it is a 2-year plan. As with all of these things, we've got some practices that are further along the path to transformation than others. And part of what we want to do is to support all of our practices and learn and share at that good practice. So share some of what those forward running practices are doing with some of the practices who find this more challenging. So I think at a future committee, maybe in, I don't know, that perhaps into the spring, early summer, we'd probably be in a better place to do an assessment of progress so far and the way still to go. Because I think we'd have a clearer picture then of impact today and how we can support those practices to achieve the ambitions they set out.
Yeah, that would be good. Thank you. Okay, Councillor Hussain.
First of all, thank you in terms of the improvement in probably some of the face-to-face appointment. But the picture you have given me is not what I get in from my constituents. The reality of life is, and I can tell you, I represent Farley and the Leavale Medical Centre. An average telephone is about 45 minutes just to be answered. You could get to Bedford and back sometimes, and you still haven't gone through. The other problem is in terms of the referrals. When you're doing that, a lot of elderly people are not literate in digitally, and they're asked to do those things digitally, which they can't. They can do a little bit of the basic, but they tell me they can't. Yes? So how are we going to take those most vulnerable people who need the most in terms of the primary care rather than finish up in the hospital if we are not trying to facilitate them? So how are you going to, because this looks very positive, but that's not the real world that I live in.
Thank you. And I think as I started to present, we're very proud of the work that our teams do every day. It's a significant number of appointments and work. However, we know that the experience of a number of our residents is that they can't make contact with their practice easily and they can't get an appointment. And that is something about the increase in demand and how we match demand to capacity. So all of this transformation work that we're doing is trying to address that, which is out of balance at the moment. There's a high number of demand, and whilst our teams are continuing to deliver more and more appointments, that isn't sustainable, and we know that there is still demand that potentially isn't being met. So our work to try and use all parts of the system to think about alternative services where it's safe and clinically appropriate to do so is aimed to support that. So we're very aware that the positive news around activity and increases activity, there is still that poor perception and experience of residents, and that is what we're working hard with our practice teams to try and balance and to try and address. In terms of the population who can't use the digital technology, we need to get that right, because absolutely our approach as an ICB and as an NHS is not about digital is the only way. It's about digital first, not about digital only. So if we do have residents who can't use digital technology, the personalised care approach should be that we understand that there are blocks to that resident using digital technology, and we should enable other ways of access for them. So we are mindful of having that right approach for our residents.
I think in terms of looking at the figures, and the figures really, you know, the Director of Public Health is sitting here. Luton is going in literally in every sense, whether it's cardiovascular diseases, diabetic, most of things, the increase is going up and up. We need to be preventative at an earlier stage. When they decided to do a number of things as an experiment, as a pilot, those have worked for years. So, you know, learning from the past what we've done, isn't it time that we are, you know, testing more people at the age of 40 or 50, whatever, for diabetes and other things, so that we can prevent these things at an earlier stage? So what are we doing in terms of those that really, because certain areas of town, we know by each road in the town where there is a major and serious problems. We've got that much data already. So shouldn't we be targeting those areas that have the worst health in terms of Luton I'm talking about? I'm not talking about the rest of the Bedfordshire.
Absolutely, and through the work that we're doing with partners in terms of our preventative approaches, we are trying to do that, and our focus in integrated neighbourhood working is to use population health management data and really target interventions to communities and to populations that address the levels of need. And we've seen huge successes. The National Diabetes Prevention Programme, Luton has been consistently one of the highest areas of take up of that offer. So the things like that are extremely positive, but still considerably more that we can do, and we are planning to do and aim to do.
Can I ask that we get a report on some improvements in the future sometime in 6 months' time?
Do you want to respond to that, Amanda?
I've missed that question, I'm sorry.
Ask that if we can have a report back in terms of the improvement in 6 months' time, rather than as much as I would love to see positive improvement, the figures that do not encourage me to see that, unfortunately.
So are you seeking a report in terms of access improvement, or in relation to your last question with regards to prevention? Just so I'm clear on the task to bring back.
Access and in prevention, the initiatives, then what are the impact it had, please? Yeah.
Okay.
One more question, Councillor Umayali.
Thanks. It was good to hear about the prevention and screening programs and how they've improved and you've identified people with prostate cancer. I got an email recently from someone that works in CCS, and it's the first time ever as a counsellor that I've had an email, and it's about the diabetes prevention program, asking for support to come to our coffee mornings and our ward surgeries so that they can promote these programs. Things like that definitely should have been happening sooner and needs to happen more. I don't know if any other councillors got them, but I got that in my ward. So I was really, really happy to see that, but that should have been happening for a long time, and that needs to continue to happen. We are here to help you, and if these programs are happening, we can get to the community because we know the community. That's one thing I just wanted to point out that would be helpful. When we were talking about the telephone waiting lists and things like that, waiting on the phone, we've spoken about cloud-based telephony loads of times before. Has that rolled out? Because not many surgeries are using that, and we keep talking about it every few months. We do these updates and we talk about it. What's stopping that from being rolled out in every single surgery, as well as the online GP access? And finally, at the last meeting, I requested an update on Wenlock Street surgery, the one surgery in my ward that had been shut down, and we're looking at using the premises for other primary care services. And I didn't get an update, so it'd be useful if we could get some soon. Thanks.
So thank you very much for your kind offer of support. I think that's really helpful, firstly, and really important that we utilise those offers. With regards to cloud-based telephony, we've just entered what we call phase 2 of the rollout of cloud-based telephony. So by March 2024, all of our practices will have access to cloud-based telephony. Now, implementing of cloud-based telephony is sort of, you implement the kit and you get the practice connected, and then there is a training piece in terms of using all of the functions and the practice reviewing their processes and how they manage their workforce and workload to use their functions of that cloud-based telephony well. So I think that whilst by March we'll have all of our practices with cloud-based telephony available to them, there is then an implementation piece to do the staff training and really embedding that technology as part of the practices, systems and processes. So it is part of our transformation plan throughout 2024 23, 24 and 24, 25. And then your final question, and I do remember you asking that question last time, and apologies for not following that up with you. But if I could hand over to Beth, I'm sure we can give you an update with regards to Wenlock Street and the premises.
Thank you, Amanda. So we are continuing to work with Dr. and Mrs. Saleh about the premises. They're the owners of the premises, and we're trying to work with them to secure use of the premises going forward. There is some work that needs to be done on the building before it could be used by anybody else, which they have committed to do. We asked them just last week for an update and timescales on where they're up to with that. So we are still negotiating and working with them in our hope and our aim to secure those premises for other health services in that area.
Thank you. That's great to hear, especially with all the vaccination programmes and other things you're doing. That would be really useful to use if we're not using it as a GP surgery.
Councillor Isles, you have a question if you can be brief.
I will be brief. Thanks, Chair. I just wanted to find out how you are monitoring the surgeries with the 8 a.m. rush. How often, how frequent, and how it's been monitored. If we could see something on that with the various surgeries, please.
Yeah, thank you. So each practice has set out a clear plan in terms of milestones and timeline of the work that they're going to do to move from their current model to a modern general practice access model. As I've already explained, it isn't a single model. There will be variations of it, but the principle is that we should facilitate easier access via the telephone, and when people do get their call, when they do have an incoming call, it's answered more quickly, and when it is answered, that the patient knows there and then how they're going to be dealt with, that we reduce or we take away that request to, sorry, we're full today, please call back tomorrow, because that is a really poor experience for residents. So each of our practices has set out a plan, and as I've explained, that goes through to May 2025. So it's a 2-year plan. So we've got milestones with each of our practices that we're reviewing their progress. And obviously there are indicators and data that we can collect via our practices from their cloud-based systems. So we do have a quarterly approach of reviewing and monitoring progress with our practices. We also have a regular approach of practice visits. So we work with each of our practices and we offer a support visit regularly to review their progress across a number of areas and think about how we can support them and what progress that they've made. So that is a core role of the ICB to provide that support and that oversight with practices. And as I said, a future meeting probably the most useful in late spring, summer, we can give some progress update of the practices journey in terms of delivering modern general practice access.
Okay, thank you. Thank you, Amanda and Beth. If we can move quickly on to agenda item number 8, overview of the forthcoming CQC inspection of adult social care.
I'll be presenting that. Thank you. I'm Harpreet Kaur, the CQC Assurance Lead for Adult Social Care Services. I'll just summarise the paper because I'll take it as read. So what the paper does is provides an overview of the CQC inspection process for adult social care. This is a new assurance process and a new that has come about since the changes to the Health and Care Bill in 2022, where CQC were given additional powers to inspect adult social care services under Part 1 of the Care Act. Since that time, CQC have been really working hard to fine-tune their assurance framework, and they've done that by working with 5 pilot sites to test the framework and make any improvements for ongoing inspections. That process has been completed. They're now at the stage where they are starting to inspect the first cohort of 20 local authorities, and thankfully Luton isn't one of them at the moment, as far as we know. So in preparation for that, we've been working quite hard to sort of continue preparing. We've been working on completing our self-assessment process to critically review our services, understand our strengths and gather our evidence and understand where we need to improve. We've also had a challenge session with one of our peers at Essex Council. We've had a challenge session with an ex-DAS, and there's been some workshops with staff, and we're using the learning from the pilots to kind of look at how we prepare for ourselves. As part of the process, we will be expecting CQC to be on site, and they will speak to a number of people, which includes members as well. And that's listed in the actual report. The only last thing to say is, you know, one of the risks is around what would happen if we are rated as requires improvement or inadequate, and there is a risk of additional resources that need to be implemented if that is the case. But we are mitigating that through our transformation programme, where we are looking at addressing all the areas for improvement and just strengthening the quality of our services anyway. So any questions?
Thank you. Yeah. Are there any questions? Councillor Hussain.
Just really in terms of those files that have already been done. I mean, only one is RI, so that's a pretty good news that the others have managed to get through to good. So we've got a pretty good chance of beating that. I hope outstanding. Can I ask you, in terms of the caseload, is one of the things that we found in children's services from my experience, yeah? And they do go, and then the voice of the carer, and in children's services, voice of the child, which probably we were not as strong in both of those. So that would concern me very much, that if we are to really take this, you know, in terms of those risks, that we need to get those two right at this stage so that we know where we're going. And also at the same time, if I could ask you, in terms of understanding the weakness in the system, that you know, and you be frank with them right at the beginning.
I'm happy to take some of the questions. So I think you're absolutely right, Councillor Hussain. Knowing where the areas that we need to improve on are absolutely key, and also being able to articulate what we're doing to make those improvements. And that is why we have already done our self-assessment, and we have got our improvement plan. And if we discover anything else, then we would be adding to that to make sure that's there. I also think it's absolutely right that you mentioned the voice of the residents within that. And I would say that's an area that we're not as strong as we can be. So we are already making improvements in there, and it's one of the key areas that we'll be developing over the coming months. But we are starting to make progress on that. We're already having a lot more engagement with people when they're complaining. So we're definitely improving our practice and being able to articulate how we are making those changes. So I'm confident that we will be able to respond to that. Whereas we may not be a perfect service, we will understand our weaknesses, and we will have plans in place, and our staff will be able to articulate how we're going to make those changes.
If the inspection was held today, would we pass?
So given there's only 5 pilots happened, I think it's really difficult to make that call. and kind of it's not a pass or fail anyway. It's a grading. So I think at the moment it's really difficult for us to say. We know that we've got areas of challenge, and in some ways it's how confident we are in able to address those. So I think any council in the country who was trying to make that call right now would be, you know, I could false prophesize, but I think it's really difficult to call. Richard, we definitely have got some areas of challenge. We are working on those, and so therefore, you know, I hope that we would have less areas of challenge in the future. But right now, I think it would be difficult to call. We have got some. You know, COVID has been an immense pressure on us. We have seen this year 16% increase in demand. That inevitably means that it's difficult for our staff to manage all of that, and there are some areas that we will need to improve.
So, can you give could you give a reassurance that you're confident that when the inspection does happen, then everything will go well?
I'm as confident as I can be. We are preparing like mad, and every extra day we have to prepare, I'll be more confident. But they could say that they're coming tomorrow, which I'll be less confident than if they said they were coming in 6 months. But that's life, and we will have to deal with that when we get there.
Okay, thank you. Councillor Nessa.
Thank you, Chair. We actually heard about that in the last policy group, so it's now asking for progression. That will be too early to ask. But I think whether I missed it about, you know, the announcement on these 20 local authorities are, which is made on December, I believe. So are we, what the outcome, are we one of them?
So actually, we should have updated this paper slightly, because that was their original intention, was to announce the first 20 in December. But actually, they decided not to do that. So they only announced, I think, additional 5. And the reason for that is they want to give everyone the same amount of lead-in time. And they've only got enough inspectors to do 5 at any one time. So we went in the initial 5. In the eastern area, Suffolk has already been inspected as part of the pilot, and Hertfordshire is part of that 5. So my bet would be we probably won't be in the next lot, because it's a big country, there's lots of boroughs, and eastern regions already had quite a bit of attention, but we just don't know. It is the reality.
Thank you.
Okay, any more questions?
Very quickly, when's the next one's going to be announced?
So we expect that will be round about, they want to give around 8 to 9 weeks notice. So if you think they've announced December, so then they wouldn't be inspecting those areas until February. So we think maybe at the beginning of February, but again, they haven't given us any timelines, and it might be another 4, it might be 3, it might be 6. We just don't know.
So this process of preparing for the inspection, how does that dovetail with the strengthening adult social care programme? Are they presumably that complementary and they have the same general goals? But it's I assume that we're not just working towards passing the inspection. It is a general programme to improve adult social care.
Yeah, absolutely. So just like children's inspection, this CQC inspection is looking at the whole function of adult social care and everything that we need to do in relation to the Care Act. So what we've done in terms of the strengthening adult social care is look at those areas that we think needs the most improvement from our perspective, from our self-assessment. So and some of those things are you know, things that we want to improve, such as co-production. We think we really need to work on our resident voice within things. Some of those things are data and our presentation of data so that we can understand our services better and wouldn't necessarily affect practice. So the CQC wouldn't inspect that as such, but they would hope that we are, you know, strength-based and understand our data going forward. So it's a range of things, but they are the most important thing within there, I think, is our what we call our target operating model, which is the customer journey through our service, which teams they have contact with, how quickly we deal with their concerns, how quickly we're able to put services in, and how our team is structured. And that's one of the key components of that. So when we get that finished, which will be sometime in the next 6 months, then we will be in a stronger place with the right resources in the right areas that will improve all of our practice in relation to that.
So I guess at the moment it must be very busy and the staff must be feeling under a certain amount of pressure and stress.
So the feedback from the staff actually has been really positive in that they are actually working with us to do that redesign, and they're co-producing it with us. And actually, they are saying that they feel really valued in the service at the moment, and that they've never had any kind of change done in such a collaborative way. So actually staff morale, I think, is actually really high at the moment, despite some of the pressures. And we are starting to see some changes, some improvements in our waiting lists and our reviews. And again, that just makes people feel good about it. And we're doing lots of celebratory events. So my view is that staff morale is actually quite good.
Okay, that's good. That's good to hear. There's nothing else. Thank you very much, Harpreet and Jill. There's 3 recommendations. I think we can note all of those. Okay, thank you. Moving on to item number 9, the Adult Social Care Travel Assistance Policy Consultation.
Yes, hello, great. Good evening, Chair. My name is Barry Yakub. I'm Provider Services Resource Manager. Hopefully you've all had the chance to read the policy and paper. I'll give you a very brief overview of this, and at the end I'll welcome any questions. We are looking to consult on the travel assistance policy, which has been co-produced with internal stakeholders. The policy reinforces our current practice, which is based on a strength-based approach. And the policy provides consistency, governance, accountability around our practice. The main principle of the policy is to utilise. It's primarily focused on utilising community natural support systems that people have in place. So rather than look at family support in terms of getting transport, we've been doing that through COVID. We've noticed through this it's been a better travel experience, as people do not have to sit in transport hours. It's also been better for families, as families have also found that they don't have to wait for transport. We've also placed people closer to home, so they can actually take people to their day activity. The council will support transport if they are unable to arrange or access transport independently. We also balance this with our commitment to family care, ensuring they do not experience economic inequality, as council transport allows many families carers to work. We would like to engage with citizens of Luton using various platforms and looking at online consultations, face-to-face, Zoom meetings. We want to target as many people as possible. We're looking at various locations in Luton, but I think that main point is around trying to go out and see people, as many people as possible, not relying them to come to us, trying to work with other organisations like Advocacy, Health Watch, Care Essential, and trying to create equilibrium by going out and removing any communication blockers. That's generally it. If there's any questions, I'm welcome.
Thank you. Yes, any questions? Councillor.
Yeah. Well, just a question in terms of the consultation, because the figures it says in the report and the figures we got is that there is an increase in children with a severe disability that will be coming to the adults. So if we're doing the consultation, I think it ought to be very thorough.
Yes.
At this stage, because the numbers increase are somewhere around 40%.
Mm.
Yeah.
Yeah.
And that will put a huge pressure on on the services, particularly in the terms of the transport. So if we are doing a consultation, we need to take into account the increase in the numbers. So are we, emphasizing that consulting those parents who would be in a few years' time will be asking for your services?
Absolutely, they are part of the consultation process.
And I think just to add to that, as part of in children's services, there is a duty to provide transport, and there is not such a similar duty within adult services. So talking to them about that change that would come as their child grows up and becomes more independent is really important, and to help them manage that transition. Now, if their young person has got a severe disability and the family is not able to provide any transport themselves, of course we will continue to provide that. But what we want to do is stress that that building the resilience and helping people to become more independent is really helpful, and that's what we've shown. In actual fact, the families have congratulated us and said, actually, why didn't you do this before? We were too heavily reliant on you. It's actually some of the time people were sitting on transport buses for over an hour in traffic. And now that we said you can go to the centre nearest your home and move things around, they can get their loved ones to that centre within 10 minutes. And it's much better for them. They're not sitting in minibuses waiting, especially in weather like this. So it has had some really positive benefits. And that's why we're going to talk to everyone in very much detail about what the responsibilities are of the council, but also how we will support them to make those journeys as simple as possible, as well as being able to support them should they need it.
I was only the reason I asked the chair is those children, with particularly those that probably with complex needs, and those with autistic ones are the one that I have in mind, where if the bus is late even by 5 minutes, they get very, very upset, and sometimes could get very violent as well. So that's what I'm taking into account, that consulting those parents at an earlier stage would be very helpful, because when they become adults, they still have a similar problem when they go into the day centers or others. And if the parents are able to do it, fine. If not, we need to be prepared, because they will need a very specialist care in terms of transport. That's what the increase, and because the budget is already overspent in every local authority up and down the country, we're no exception, but our increase is far above the other local authorities than ourselves, so we need to be prepared for that.
Thank you. That's just perhaps not strictly relevant, but is there a similar piece of work going on with children's services, and we touched upon transporting children with learning difficulties?
So children's already has had a policy in place, and this was actually we found during the transformation that the transport, looking at the transport of the, sorry, I'm losing my words. So we have the transport department within the council. The majority of the work that they do is for children's. Because of the overspend, we're obviously looking at different models across that and seeing how we can manage that. And one of the things that came to light was actually that adults didn't have a standalone policy. And so we're closing that gap. They do have a policy, but their statutory duties are very different than ours.
But that work would have informed the work that you've done on this policy.
Yes.
Okay, I just have, I think, one more question. Paragraph 5, the policy aligns with other neighbouring local authorities. Was there any kind of consultation with other local authorities, or is it just a review of their policy?
Just a review of their policy.
thank you. If there's nothing else, so we're asked with recommendations. We've made comments, and I think we can note the fact that it's intended to seek agreement to exempt this matter from call, and that if there's no major changes to the policy, it's planned to submit the policy directly to executive. So I imagine you're not anticipating any major changes. Okay.
Yeah, we don't know, but not anticipating any.
Okay, thank you both. Thank you.
Thank you.
We move on to the next item, number 10, housing and health.
Good evening. I'm Chimamanda Buta, I'm Public Health Service Manager, and I'm just going to be presenting a bit of an overview on the work that we've been doing around housing and health as it sits within the wider context of the population wellbeing strategy and health equity town work. So, as you know, housing is obviously a really important determinant of health. It doesn't take much to think about the importance of housing, good conditions, good living conditions, and how it impacts on our health and well-being and families. And obviously, if you don't have a house to live in, there are impacts on your health in general. So as part of the Marmot review and the Marmot report, we did focus and did some work around housing and how it impacts on poverty and the effects that it has on the health and well-being of adults and children, and in particular issues around non-decent homes, fuel-poor homes, overcrowded housing, and unaffordable housing. And within that, we've got some policy areas that we are working towards. So these areas are ensuring a healthy standard of living for all, creating and developing healthy, sustainable places and communities, and strengthening the role and impact of ill health prevention, and finally around business. And these are the areas that we think that housing can influence, or good housing, doing joint work with health and partners, can actually have an influence on our residents' health. So in this paper, as I said, it's an overview. It's not an exhaustive list at all, but there are 4 areas that I did want to bring to your attention. So the first one is the Tenant Satisfaction Measures Survey, which is done every year, the Healthy Estate Strategy that we're working on directly in public health, the Health Equity Town Housing and Health subgroup, which is a reasonably new group, and then what we're calling Core 20+5, but the actual project is Warm Healthy Homes. So quick overview is that the Tenant Satisfaction Measure Survey, some of you may know, as a local authority, we're obliged to do one every year, and we had quite good response rate from our tenant households. We had 928 responses, which is a 29% response rate, which is generally in the higher echelons than other local authorities. And we did ask tenants some questions around health and well-being, and in particular what their awareness of the services that we offer in Luton. And what we found is that 50% of respondents were aware of Luton's Total Wellbeing Commission service, that's by Public Health. We found that what people knew about most was the Stop Smoking service offer, and that unfortunately only 19% have used at least one lifestyle service. What we did note was that there's quite a low response rate for physical activity. Only a quarter of the tenants that did respond that were doing physical activities. 30% were leaseholders 13% of those leaseholders, only 13% of them took 30 minutes per week of physical activity. So that's quite a low response rate. And finally, we found that 35-year-olds took quite low activity levels compared to the 26% of people aged 35 to 49-year-olds. And as people got older, they did less physical activity. As I'm moving on to the Healthy Estate strategy. So this time last year, Public Health started working with our housing colleagues through action. So we've been working with them by developing the Healthy Estate strategy, but now we're in the action phase. So we worked together with our housing colleagues to do some action, and we felt that we wanted to identify the needs and involve local people in understanding the issues around housing, promoting health and fulfilling lives, and then providing attractive and diverse green spaces and what that meant. What's come out of that is that colleagues have been involved in roadshows, concierge roadshows, where they've asked tenants through survey work to gain an insight again into what they felt was positive around the estates and what they felt needed improving. If you look in your notes, you'll see that table 1 shows these are the kind of interim findings, and we call them interim because we're still doing these road shows. They're still continuing. So what some of the positive factors were that the housing design was really good. It was a nice livable space. They felt that it was safe, places to walk, and there was reduced littering. Some of the areas that needed improvement were needing to meet more people, opportunities to meet new people, improved communal areas, and an improved outdoor space. So for us in public health, the next steps are to continue with those and continue finding out across the borough where these concierge roadshows happen, what people are thinking, and collating them and sharing that good practice and engaging with others, and then going on to look at what we can actually action that's meaningful and will have an impact on people's, certainly their mental well-being, but also their physical health as well. I'll move on to a housing and health subgroup. As I said earlier, this is a reasonably new development as part of our Health Equity Town movement. And this is chaired by our head of housing, I think that's a job title, Claire Asprey. And it's a subgroup that just pulls together all partners and stakeholders who might be interested in it. But what we wanted to do was look at the review of the Marmot report that we received. It's been a year since we've had this really great report with lots of insight and lots of data, and just sense check it again with colleagues to see that it has the right information, the right recommendations, and it's still relevant. We did a gaps and opportunities session, and we found that we were happy with the opportunities around the healthy estates and moving that forward. We wanted to do a bit more around effective partnership working and making sure that we're targeting vulnerable people. We want to use our data more and continue to do that to prioritise areas of housing in the borough. So this is where we found gaps. We found that it was really important to intervene early and to do some prevention work early. We wanted to utilise the wider housing partnerships, so in particularly developers as well, and get them involved in the conversations and thinking about letting agents as well. And then, as I said, sort of following on, working with our planning colleagues to address the medium to long-term requirements that we need, particularly around the future of older people and the needs that they have in their homes. So next steps for us is to continue that group using the Health Equity Partnership group that has been morphed from the Health Inequalities Board to deliver some of these actions and to keep a watching brief on it to make sure that we're making an impact, which will be fed up into obviously this committee, but also the Health and Wellbeing Board. The last project that I wanted to bring to your attention that's quite exciting is that we received funds from NHS England and our ICS, which has come through inequalities monies, called 20+5 funded, the warm, healthy housing. This work is looking at energy performance and looking at really regulating poor standards of homes where the energy rating is really quite low in the band D levels. So we've funded an officer to come and look at those houses and start enforcing some better energy ratings within private sector homes, which is where our greatest need is. So the ask is of this committee is to really just endorse what we're doing, keep a watching brief, and if there's any kind of recommendations or thoughts that you have around housing and health, it doesn't necessarily mean we're not doing it, but maybe I could bring it again and we could discuss it in future meetings.
Thank you. Does anyone have any thoughts or questions or comments? Councillor Hussain?
Not a question, but question to somebody. Have they turned the ruddy heating off or something, or what? I'm feeling freezing cold in here.
You're right, it is freezing cold in here. Yes, I have no idea whether...
Can somebody do anything about it? I mean, this is the third meeting I'm attending here, and it's absolutely disgraceful. It's not acceptable. No, we're talking about health, and for God's sake, you can't even look after the members here and the other people that are in this room. Yeah, I mean, that's not acceptable. And they need to get the message. But I will do an email to Chief, because we are doing savings, but not trying to give us an pneumonia first.
Councillor Hussain, could you switch your microphone off, please? Yeah. Yes, no, I agree. It's not acceptable. It is freezing cold in here. What I gather, nothing can be done at the moment, but hopefully future meetings it won't be an issue. Okay, if we can carry on. Does anyone have any questions for Chamimi? Okay, I've got some questions. The core 20+5 funded project, the warm, healthy housing, presumably that is just for energy performance. I know recently in the press there's been a lot of talk about mold and spores and the effect on respiratory diseases. Is that something that's being looked at by enforcement? Presumably not part of this project, but is that something that is being considered?
Yes, Chair. Sarah Markham is lead for that, and as you know, that child in Rochdale that had died, we're trying to not follow suit, but see how we might improve our housing, looking at how those conditions impact on children's respiratory. So Sarah Markham is leading that, but I haven't got the detail, I'm afraid, but I know that's being worked up, if not already being implemented.
Okay, yeah, thank you. I think not so much questions as comments. I think this is obviously can be split into two parts: maintaining and improving the existing housing stock, and considering planning and developing healthy homes in the future. And I think personally what I would like to see is more about the second part, about building healthy homes for our residents. I think you mentioned it, paragraph 20, utilising the wider housing partnership, including developers, state and letting agents. Presumably that's what you're talking about there. It's getting all of these partners involved in the process. It's tackling this problem of building affordable, healthy homes. That seems to be the circle that needs to be squared.
We've got Sunny in the room, head of planning, so I wouldn't want to speak for him, and we're fortunate enough that the time for the local plan is being reviewed, so we want to be able to influence that, and that's all part of this. And the health and housing work, I'm hoping will influence those policy developments that are there, but it is a challenge and we're really aware of it.
Thank you. If there's nothing else, the proposal is that we maintain a watching brief the housing and health actions and receive regular updates on progress. And I think we can agree to that. Thank you. Moving on to item 11, Luton All-Age Mental Health Strategy.
We've got a few slides to share.
Could you introduce yourself?
Sorry, yeah, I will. My name's Gabby Wolf. I'm a public health registrar in the public health team covering the mental health portfolio. Right, so I'm presenting our Luton Collaborative All-Age Mental Health Strategy. Just a bit about what the actual strategy is. So this is a co-produced high-level strategic approach by which Luton will take to improve mental health of its population. So we recognise this as a high level. It will underpin our more detailed action plan, which will form a separate document, and this will then be used to implement our priorities according to this strategic approach that we've laid out here. Our strategy recognises that Luton has its own specific needs, which differ to those of Bedfordshire and Milton Keynes. So although BLMK, ICB have their own have a cross BLMK mental health strategy, this one really recognises these very specific priorities of Luton. So we have our young population, very ethnically diverse population, and then all the health inequalities related to poverty, unemployment, homelessness, substance abuse. And to recognise that this is not a Luton Council strategy. This is a partnership strategy, along with our providers, with the voluntary community sector organisations, across all parts of the system, ICB, and of course our people with lived experience, carers, have also been very heavily involved in the development of the strategy. Of course, one very important part of it, this being a Luton specific strategy, is that mental health is key to our Luton 2040 priorities. So this will be something that we can use to help to deliver Luton 2040, and also to use our principles from being a health equity town, our findings from Talk, Listen, Change, and also from the Denny review as well. So we have a lot of very Luton specific kind of evidence that we can use to take this forward. The purpose of bringing to Scrutiny today is to note the content of the strategy and its priorities, and to give an update as to where we are, and for agreement for the strategy to go out to public consultation. So far, we've taken it to Health and Wellbeing Board, we've taken it to CLT, and actually it was previously a separate adult and child and young person strategy, but at the request of Robin, we've now join those two together, and actually I think this is really important because it reflects the fact that that there isn't a silo of children, young people and adults, but actually it's all very, very interrelated. Children obviously don't live in isolation. They are surrounded by a family and community, which of course includes adults, and that 75% of mental health conditions begin before the ages of 24. So real true primary prevention of mental health needs to be focused very much to children and young people, and as well as recognising the impact that kind of parental mental health has on children, so that kind of real intergenerational effect of mental health. At the moment, we're in the process of, we've set up a system leaders group for delivery, and that's just sort of getting started at the moment, and we're planning an implementation workshop as well. Some of the specific issues in Luton that we're wanting to address, there's a high proportion of people with mental health issues in Luton compared to the England average, and we also have a higher proportion with severe mental illness. And while we know that people with severe mental illness are more likely to die earlier, that is even more profound in Luton than across England as a whole. We know that severe mental illness is also associated with deprivation and is more common in those more deprived areas of Luton. We also know that a high proportion of Luton's children and young people are accessing mental health services and are requiring inpatient admissions compared to the England average. And the proportion of children in care for whom emotional well-being is cause of concern is higher than in England as a whole. Just trying to move on here. We also have specific issues around access. Diagnosis in primary care for common mental disorders, so conditions such as depression, anxiety are lower than we would expect. There's complications with people who've got dual diagnosis, so people who've got substance misuse problems have historically had difficulty accessing mental health services and vice versa. There's been challenges around transitions and waiting times for people who are leaving children's services and trying to access adult services. And we also know that access to services is lower for those who are not of white British ethnicity, as are recovery rates. And this is just this graph just illustrates how that we're showing much larger numbers of white British accessing services, both adult and child and young person services. And that's disproportionate compared to the size of the white British population, and Asian, black ethnicity are underrepresented in people accessing both talking therapy services and some child and young person's mental health services. This graph here, this just compares demand for community mental health teams across BLMK, where we can see that Luton has the lowest demand. And looking at acute adult mental health wards, where you can see that Luton has the highest demand here out of the three parts. Sorry, this is Bedford Borough and Central Beds and Luton. So you can see that the population of Luton is less likely to access community mental health services, but more likely to access acute beds. This is just some of the co-production. Well, this is the co-production we've done around the adult strategy side of the strategy. We've worked very closely with the Reimagining Mental Health Collaborative, which is a group, we've got about 90 members across providers, voluntary community sector organisations, parts of provider organisations, ICB, people with lived experience, carers, so kind of a really wide-ranging group of people, and they've been this has kind of been developed along with them. We've also have engaged with a number of other groups, people with lived experience groups, people with using social housing as well. And this is some of the children and young persons co-production and consultation we have carried out as well. And we've also commissioned the University of Bedfordshire to carry out a piece of work to understanding the experiences and perceptions around mental health amongst young people and their families of specific ethnic groups in Luton, and that's going to be published, I think, sort of within the next month. But we have already got some preliminary findings that have contributed to this, and that will continue to contribute to our action planning. And this is just some of the things that people in Luton have been saying. You know, people getting frustrated when they get turned down when they try to access services, not being consulted about what is needed before spending money on something that might not be wanted. People not necessarily only accessing support at crisis point, but they feel that that's actually the only point where anyone actually takes any action. And then kind of, you know, the issues around feeling that the mental health services and the drugs and alcohol services don't work together enough. This is our co-produced vision and outcomes that we worked together, the Reimagining Mental Health Collaborative developed together. So the desired kind of vision for Luton is that it is a community where one feels listened to, believed, understood and supported to become the person they want to be. And these are the principles that the Reimagining Mental Health Collaborative came up to as to kind of underpin this the strategy and the way we take mental health work going forward. So looking at it, starting from a social model, using an underpinning work by a trauma-informed approach. So not looking at what's wrong with that person, but what's happened to that person that has led to them being, having these mental health issues. How can we support, the wider kind of structure around that individual to help them to recover from their mental health condition. Looking at ensuring that we're considering the client needs and wants at the centre of the approach, and being really aware of that power that's inherently present in the kind of professional and client relationships. Ensuring that we're really empowering an individual, and we're ensuring that we're kind of getting engagement from all agencies and getting people to work together and sort of integrate all the different services out there so that they communicate better. Listening to all voices, ensuring that kind of resources, if necessary, are actually redistributed, kind of reviewing how those resources are used. And agreeing collaboratively the services and the resources that are needed, and thinking about how things can be done differently and what outcomes we want collaboratively. Okay, so these are the main priorities that we've come up with. So prevention, this is primary prevention, as I mentioned, which would be very much focused, thinking about children and young people and relationships and communities around those young people, but also preventing people from their mental health worsening, and prevention of reaching crisis. And then, as I mentioned, there's also a number of identified issues around access, to make access easier for different groups of people who may not be accessing appropriately or kind of sort of early enough as they should be, particular kind of ethnic groups and other groups that may struggle to access services. And it also includes cultural competency in developing services. Underpinning all of this is the real need for integration. Lots of this is kind of that this work is, or it's not. None of this is new. We're not going to start right from scratch. But what we really want to do is make sure that we know all the great work that's going on around. We bring it together, make sure the population actually knows about the work that's going on, and that it's all joined up, and that we're kind of, the people are communicating with each other and sharing information. We also obviously want to make sure that good quality services and improving the experience of the population when accessing services. These are just some visualizations of some of these concepts. So the importance of social factors on mental health outcomes, making sure that this is kind of really at the centre of the work that we do. considering that psychosocial model, recognizing that you need to, that you don't just need to fix that individual, you need to be thinking about what is going on around that individual. And as I mentioned, the trauma-informed approach, it's not about what's wrong with you, but it's, what has happened, and thinking about kind of strengths as part of that management. So this is just our timeline going forward. We're, as I say, we're going through the council consultation process with the aim of taking this out to public consultation there'll be kind of an online survey, but we also really wanting to make sure that we focus targeted specific groups who will not necessarily be accessing the website and any surveys available on it. So looking at people with lived experience with different particular conditions, and ethnicity and faith groups as an example, and children and young people as well. And then the next steps will be further developing our action plans, ensuring we've got a data dashboard to monitor outcomes. This will be co-developed with our partners across Luton, and we'll be setting up workshops to do that as well. We're establishing our system leaders group, and we're developing our governance structures around this as well. And we'll also be kind of making sure that we are drawing support and leadership for addressing the wider determinants of health, and ensure that delivery is measurable in terms of outcomes. So that's it for me. Any questions?
Thank you, Gabby. Just to start off with, so there'll be separate action plans for young people and for adults. Is that right?
Yes, sorry, I hadn't mentioned that. Yes, so whilst we have combined the strategy, we recognise that actually in terms of delivery, we'll be talking about very different stakeholders and providers, and we'll be wanting to engage with different groups of people for developing and implementing those action plans. So yes, those two will be separate.
And do we have a timeline for the development and the implementation of the action plans?
So we're in the process of setting up a date for the adult one, which end of February, beginning of March. We've had some kind of difficulty kind of getting the date in the calendar, but yeah, so that's kind of going to be the workshop for the adult one, and then we'll be looking at March for the children and young persons one.
Thank you. Does anyone else have any questions or comments? Councillor Ambia.
Thank you, Chair. I have a question on page number 52 on next step, point number 19. You mentioned about the page second line. In addition to sharing online survey, focus groups for children, young people, adult, and there are people who doesn't have a online facilities, or they are not a computer literate, especially Asian communities, or the adult people, because these are the main target group. So is there any way you have a different approach in parallel with online survey, like kind of like standing somewhere in a shop, public place, and take random, or have some door-to-door visit, and or to target to the communities center or mosque or something?
Yeah, absolutely. Yeah, so we, as I say, the survey is just kind of one part of that, but we're very much going to be targeting specific groups, as you say, may not be able to, or may not be accessing our survey. So we will be working with faith groups to try and access and kind of other sort of ethnic groups to try and access particular populations. So we have within the social justice team, I know, has links with particular faith groups that we can use to help to access, but also in Elft, there's some work going on at the moment with the South Asian community. So they have really good links with members of the public who have sort of engaged with work around mental health from that population, and they also have very well developed service user groups as well that we can sort of feed into for engagement. So we're aim to kind of use a number of different resources to try and access different groups as much as we can, very much recognising that when a survey online isn't accessible to a lot of people, and we're not going to get everything that we need from that.
I would recommend you can also include counsellor as well, local counsellors. So basically, if you speak to the faith group, you're targeting to the male group. They may not share information to their partner, especially women, to reach to the women directly. Maybe some door-to-door or some other way to go through the community centers to target the women's audience, or maybe you can contact or involve the local councillors so they can randomly approach to a few residents, or they know where is elderly people or where there's a like where the demographic are, so they can help you to make this get correct data in order to make a decision. This is my suggestion.
That's really helpful, thank you.
And number one. Number two is on point number 20. You mentioned about run the workshop to plan implementation. So where are you going to who's your target group, or like once you complete the number 19, then you will follow number 20, or like workshop? What's the plan for workshop and how you conduct to the workshop? Is it on the local community based or?
So I mean, our plan we have a co-developed action plan that it's slightly complicated because this all started going through this process about a year ago before I was in post, but and an action plan has to be developed at that point, and I think there were some further actions that had to be through part of the council consultation process. Sort of it kind of moved back, and there were further development of the strategy at that point. But so we do have a co-produced action plan that needs to be revisited, and so we need to obviously work out what's still relevant, what our priorities are, and we're going to be looking at that in a workshop that we with our system leaders group and our Reimagining Mental Health Collaborative. So as I mentioned, the Reimagining Mental Health Collaborative is a established group that has been going, I think, for maybe about 5 years now, I understand, but it's so it has people from people with lived experience, people there's carers, there's representatives from Health Watch and providers and a voluntary community sector organisation. So it's really, I think we've got about 100 people on that list. So so it will be a combination of that and our sort of system leaders group that will come together to develop that implementation plan and kind of and decide how to take that forward.
Thank you.
Anyone else? Any questions? Councillor Hussain.
I mean, strategy in terms of public consultation and that, it is a very fine document as far as I'm concerned. I'm just making a comment, not a question really. But when we've done the consultation in terms of that, I mean, one of the most important thing is if we could have resources to go with it. And that is the very important thing, because the growth in mental health in terms of 1 in 4 will likely to have some sort of mental health. So unless there are resources, we can have a fine strategy as much as we want. But if we haven't got the resources, it is just a document. So that's my comment, that we need to have the government taken into serious consideration and funding the service, but particularly now with the COVID, for the young people as well as the adults, and particularly some of the our elderly people who are seriously facing, since the COVID, a serious mental health problems.
I guess it's funding. Funding is always going to be an issue with this this sort of thing, isn't it?
Yeah, I mean, you don't get any argument from me there, but absolutely. I mean, there is so much that if we had all the funding in the world, that we would love to do, but we're within we're kind of working across with our partners. There's trying to utilize the money that is in the different parts of the different organizations as efficiently as we can. I think there's quite a lot that there are certain things around, kind of, for example, integration and communication and making sure that people know about what we are delivering. So there's making more efficient use of the funds that we've already got by ensuring that our residents are aware of our services and they're working together better. So yes, we do absolutely recognise the limitations of funding, but there is still work to be done.
Okay, thank you. Sally, you have your hand up.
Yeah, thank you. I just wanted to come in on that funding point, just because it is really relevant. This strategy, we're having the overarching leadership for in public health, but a lot of the actual delivery is obviously outside of public health and really reliant on the mental health providers, as well as some of the sort of more the kind of health promotion-y, anti-stigma type work that we'll be leading in public health. But a lot of the money that, if you added it all together and sort of put it all together in a pot for Luton for mental health, sits with the various providers. So it's about, as Gabby said, trying to work smarter with what we've got, but not as in just the council what we've got, but across the piece for mental health as a joint resource for all of us. And part of what we're hoping will facilitate that working better is this new mental health provider collaborative approach that's being led by the ICB, but it's around all the mental health providers working together to develop what services are needed in BLMK, but at place. So Gabby's been working really closely with the lead for that to say, with that new approach, how do we get the best that we want, best that we can for Luton, based on the really great work we've already done with the strategy and how it lays out the key challenges for us in Luton and the key priorities around access, integration, etc. So it's still slightly nebulous around what that actually means, but we're really hoping we can leave us some additional focused resource for us in Luton through that provider collaborative approach. But it's an ongoing conversation. But the idea is that it makes us collectively more agile with the funding that we use for this piece of work.
Thank you. Okay, any more questions, comments? What was I going to say? I think talking about empowering and removing the stigma around mental health. Obviously, that's very important. How is the consultation sort of bringing that into the? How are you bringing that into the consultation?
So we're actually, stigma has come out with as quite a high priority, both within this actual strategy, but also through some work across within BLMK ICB around prevention work. Sort of stigma has become as a very high priority there. It's obviously has a lot of implications around how people accessing the support they need, because if people feel stigmatized, they're less likely to come forward, but also in terms of enabling that kind of support, that community support around the individual. So at the moment we're actually started developing resources for an anti-stigma campaign, thinking about how to more kind of looking at that community around the individual as to how to kind of help to keep people around and supporting an individual. I think previously some of the other campaigns are very much focused on identifying somebody with mental health problems, and kind of that actually had an unintended consequence of making people feel a bit more like, okay, they're different from me, you know, I recognise they've got mental health, I'll tell them to go get some help, but, you know, and then I'll let them get on with it. Whereas actually what our approach is more around trying to actually say, well, we all have our own sort of history in our lives. Different people have different things that have taken place in their lives, and that will all contribute to their mental health. And, you know, stay around, stay behind and support that individual. So we're in the process of developing that. Those messages have been co-produced with a number of different groups, children, young people, adults, people of different groups and professionals. So that's in progress at the moment.
I think what I was getting at is, could raising awareness be actually an integral part of the consultation, or is that the case anyway?
Sorry, I didn't really understand your question.
So the consultation process, is it possible that the raising awareness of the stigma and raising awareness of mental health could that be part of the consultation?
Right. So in the sense that you're as in that's something that we'll be consulting about, or to try and understand the importance of it, is that what you mean? Sorry, I'm trying to
yeah, so if we start from the point that we think that everyone in the community should be aware of mental health, and to try and reduce the stigma around mental health, then as part of the consultation, the questionnaires, the engagements, that you're starting to talk about this raising the stigma and raising awareness.
Yes, yeah, no, absolutely. I think, you know, every opportunity really to kind of engage on this topic, and the sort of the priorities and kind of the you know, how we want to be taking it forward, I think will you know, is really essential for reducing stigma, improving kind of awareness. So yeah, I think I agree with you on that one.
Okay, and I think the other point I wanted to make is that it's important to see mental health as part of the whole system, isn't it? So I mean, the other reports that we've had tonight about healthy eating and the what's the other one? And the hot food takeaways, healthy eating and housing. It's all part of the same thing. You get this virtuous circle of if you have better housing, you have better mental health. If better jobs, better mental health. Better mental health, you're more likely to. So you get that virtuous circle going. So it's that whole systems approach, isn't it? All these things feed into each other.
Yeah, I mean, absolutely. I mean, we know that there's the kind of 40% of mental health conditions kind of are influenced by social factors. So housing is a really integral part of that, and sort of general kind of lifestyle factors are. You know, it's a two-way relationship. All these factors are interlinked, and I think this is the thing with mental health. It is all encompassing. There isn't really an end to it, and actually that kind of makes it a little bit more challenging in terms of, you know, where do we start, where do we stop? Within the public health team, we're having these conversations around kind of, you know, recognizing that everyone, you know, within public health alone, and this is not saying that other areas don't do this, but within public health alone, pretty much everyone is doing work around mental health, and actually that we need to be really, you know, recognize that and actually try and utilize those opportunities. But then, you know, that's also the case, obviously, across the council and across the whole system. So, yeah, absolutely everything that all of us do will impact mental health.
Okay, there's nothing else. Sorry, Jill.
I hope you don't mind me coming in, and Sally also. I know you're online, but I think what you're talking about there, Chair, is about obviously the wider determinants of health, and that also affect mental health, which is absolutely key and affect our health and our well-being and our mental well-being. And quite rightly, we've got lots of strategies to address that, which intercede with that. But I do think that it's important also for us to talk about mental illness. And this strategy essentially is looking at how we support those who have become so, who's lost their mental well-being to the point of illness. And there is a big difference between that. And I think that the two flow into one another, absolutely. But sometimes we need to address the illness and the social factors around that, and the psychology and the support, as well as those wider determinants. And I think that's why we have this strategy to focus on that, to supplement all the other work that's happening.
Thank you. If that's all, thank you very much, Gabby. Thank you. And we go on to item number 12, hot food takeaways, the local position.
Good evening. I'd like to introduce ourselves first. My name is Mark van Varstelven from Public Health, Health Inequalities Teams, also covering health in all policies.
Perfect. Hello, I'm Kate Cresswell, Public Health Manager with a focus on healthy weight.
Good evening, everyone. My name's Sunny Sahadavan. I'm Head of Planning here at Luton Council.
So thank you. We have slides to accompany our report. Could they be brought up, please?
Are these the ones that have been circulated? Does everyone have a copy of this? Yeah.
If you all have a copy of that, then we don't need to bring it up. So apologies for that. Then we take that from there. Right, we take the report regarding hot food takeaways, our position on that as read. What we do here today is present it as a summary. So you find in printed version the slides that summarize our position. Again, this is about hot food takeaways regulation. The context and the perspective is health in all policies. That is collaboration between services. It sums up how we present here today from public health and from planning, and there are other services involved as well. The other element is the healthy place framework. That's a framework that embeds policies going forward. And in particular on this occasion, it is regarding food environment, but also healthy high streets. There's a key element in there. Then another relevant point is the local plan review. Sunu will expand on that shortly. This is relevant because we need to look into an interim solution, in a way, an interim approach for new hot food takeaways applications. The other element is the food agenda. That refers to where we are with regarding the food plan and strategy, but also, and we will elaborate further to that, regarding revisiting what we call the tuck-in project. If I move on in your sheets, you see the next slide. So this is about the report that we submit today. It's a joint report, like I mentioned, public health planning, but also licensing and advertising have been involved. It refers to the current situation as requested originally to submit to the board here. And it is about regulation of takeaway outlets. We summarize that on that next sheet. Further, for your information, we had a working group where we outlined the local position. It's that consisted of the services I just mentioned. So this is just for you as intro, and I'll refer to my colleague Kate to take the next slide.
Perfect, thank you. So I think has been picked up in early discussions. There is obviously that need to embed and weave in a whole systems approach to addressing and enabling healthy decisions around food across the town. So that's picked up through, as Mark has alluded to, the health and all policies approach. In this instance, we're talking specifically around hot food takeaways. So, presently we're able to work with our planning colleagues and work to provide comments on any new applications that have been received to us as a council. So, as you'll see in the slides, we consider the wider scope of those local rates, but also specifically to the location. So ward-based, if they're close to schools, in the interest of protecting and supporting the needs of our children. And we also are able to refer to local position statements. So Mark, again, has referenced those healthy place framework. We also had the healthier food and drink advertising policy that came in, that sort of formal planning policy, but it does help to reaffirm and reassure our local position when it comes to healthy, unhealthy foods. And there was also the Luton Food Plan that ran for 4 years between 2018 and 22, which is currently due for an update, which we're looking to progress with. And that needs to sort of build in an updated local context. And we've been able to work with some of our colleagues, specifically our members from the Food First network, to build into this. So just wanted to give an overview of the current process around hot food takeaways. I'm just going to hand across to Anthony from planning, who'll just speak around the future opportunities within the local plan.
And the future local plan work, it's over to you, Sunil, on that slide, please. Thanks.
Yeah, thank you, Mark. Just to remind members that the current local plan was adopted in 2017, and it doesn't contain any specific policies on hot food takeaways and prohibiting them. Instead, it relies, we have been using the local plan to make decisions on hot food takeaway applications. And what officers in the planning service have been doing is relying on a matrix of the other policies and relying on them to resist, where we can, hot food takeaway applications. And we have largely been successful in resisting them, and some of these applications go to appeal, and fortunately the planning inspector in the main has agreed with the council. So the current situation without the policy is working, but I think it's worth mentioning that in the grand scheme of things, we get very few applications for hot food takeaways. In last year, 2023, we only had one application out of 1,504 applications in total. And that application was refused. And of course, whilst colleagues in planning are happy to assist where we can, making decisions on planning applications around hot food takeaways can only apply to new premises. We appreciate that most of the concern is around existing premises within the town, and this isn't an area we can help with in the planning service. That said, we recognise that members are keen to have a hot food policy, and we are keen to include it when we review the local plan. Now, in terms of reviewing the local plan, it's fair to say that we are on hold, pretty much like every other planning authority. This is due to the planning reforms that the government are rolling out. And what's been announced is that in autumn of this year, they'll provide the new regulations that will apply across the country. And what we're doing in the planning service is waiting for that announcement. So we don't want to carry out any abortive work until we know what's required in terms of adopting a new plan. In terms of the plan adoption process, it's not something that happens very quickly. Usually it takes 3 to 5 years. And so if we look at autumn 2024, it's unlikely we'll have a new adopted local plan until 2027. That's not to say that we are ambitious and seeking to take advantage of any options to fast track a new adopted local plan. We've put ourselves forward, asking to be part of the first wave, where the government will support us in adopting a new local plan. But we'll wait and see the outcome of that. There's no guarantee that we will be one of the chosen authorities to progress a new local plan, but we have nevertheless put ourselves forward. That's all I've got on that slide.
Thank you, Sonia. In your pack on the next sheet, you'll see the title of the slide called Developing a Hot Food Takeaway Policy. I will briefly go through that, and then my colleague Kate will complete the presentation. Developing a hot food takeaway policy. This is about evidence-based working, collating data, numbers, identifying trends on that. It's about future developments. And again, it is mentioned before, but this is about a whole systems approach to including to healthy weight, to take that in account. So that's this slide in terms of the key points. Over to you, Kate. Yep.
Perfect, thank you. So sort of in summary, there's two tandem focuses for us to consider, one being the future plan, the local plan, with a policy that would affect future prospective hot food takeaways, but then also what we do with the range that we have currently in the town. So we've sort of outlined our sort of activities in this interim. So as summarised with our current approach, we continue to provide comments on any applications that come in. As Sonia mentions, there's not many that are coming into the inbox, but in terms of the ones that are currently in place, one avenue we'd like to revisit and explore again is how we can open up a dialogue with our local businesses, specifically through the tuck-in scheme that was in place under the food plan back in 2018-19. So this was a voluntary business pledge that was quite well received by the community, that enabled them to make those changes to their menu. And I think in May of 2019, it was almost 160,000 meals were impacted by this. So there's quite a wide range of scope there. And again, it's that dialogue of that, togetherness and everyone coming with those shared interests to support their patrons, essentially. We've also spoken about the whole systems approach. So health and health policies continue to really reinforce the need for all members in different sectors to weigh in on these decisions of what enables us to have, healthy decisions when it comes to food. A key part of that, of course, would be how we work with our children in education settings and early years to just work to embed and set them up for a really good life in the future. We spoke briefly about the food plan or the food agenda. So again, that's in progress and is working towards being updated. So we had a workshop in December with our Food First network, and that's begun, as said, the conversation around food and what is wanted and needed by the community. We're looking to replicate this with a specific focus on the youth with a partnered workshop, which are just working to sort of tease out the details of. And again, the Healthy Place framework that Mark spoke through at the start, these are all helping to underpin our direction as a council and as a community. And then as we look ahead to the future, in terms of the local plan update and embedding that local hot food takeaway policy into it to support and protect any future businesses that come through, the content of that, what it will look like, will be very much guided by the evidence. So that's what we need to be addressing and focusing on in this time. We can then potentially provide an update as to what that would be in due course. But yeah, I think that has covered all the details. I said you got the report to take as read alongside the slides just to complement those, but happy to take on any questions. Thank you.
Thank you. Councillor Hussain.
Can I just say that what I've heard so far today and this evening and before, prior to that, I mean, one of the things that I think all you officers are very well aware that the members have very seriously discussed this at a policy group, and this is one of the decisions the members have made, that they would like to see a restriction on that, whichever way as a one council we can work. Up till now, 7 years gone past, and it hasn't been implemented, all that. I can understand it's not in the 2017, but the evidence is there in terms of the child obesity, right? And that is all an increasing day by day. We need to do something because we're sitting on a very serious issue that we need to handle. And we need to get the act together between the licensing as well as the public health as well as the planning. And the sooner we do that, how you do it, it is for you to find a solution. And from what I heard, I'm very disappointed that we haven't made any progress even to this day. It is something that's very close to my heart because we have had premises. I do understand, Sunil, with due respect, that we can't go back on it, what has happened. But what we need to do is to look to the future, Chair, and we need to get this right. Because we are the local authority which give the licensing for opening hours. We are the authority that do have the public health responsibility. We are the authority. We have a planning responsibility. So, you know, we need to get this right. I have been talking to, I'm sure Sunil, I'm not too sure about the other officer, but Sunil is very well aware of it, that I've been talking since he's come into this authority and long before that. And we are not, and it is the policy of this council. It isn't something I've invented or it's just my view. It's a collective responsibility of this council, and we've not gotten very far. If it takes through the planning route, then we need to get on with it. It takes licensing route, we need to get on with it. It takes the public health, we need to get on with it.
Would you like to respond to?
Yes, Councillor Hussain, thank you for your comments. From my perspective, we operate within the remit of the legislation, of the regulations, but we take on board what you said about policy group. This report we submitted is about new applications for hot food takeaways coming through. We can't necessarily change the existing licensing, so that's a reality, I'm afraid. The actual numbers coming through are low. And it is further anticipating the local plan review and taking on board your comments now as well. that we have to take that on board and build that in going forward.
Sorry, did you say we can't change the license? Of course we can. Members sit on it. I sit on that. I chair that group. And we can put a restriction on the hours of operation. We've done that. I fail to understand that. That's what is that we have put a restriction. If we can put a restriction in they can't open it during the school hours, they wouldn't even ask for a license. We can do that.
Yeah, fair enough. It's in terms of I'm for public health, so we need to address that with our colleagues from licensing. So we'll pick that up in that respect.
Yeah, Councillor Ali.
Thanks. I'm also really disappointed at this report. I think it's lots of kind of like excuses. I mean, I've read through all of it and the comparisons and, you know, the other areas that don't have similar rates of obesity. And I think the figures are probably affecting, so, you know, the classification of what is a hot food takeaway and what isn't is probably affecting the numbers that we're seeing in the number of planning applications, which I know you probably can't, it's probably like a proper classification. But I just don't think this can wait until our next local plan. I don't think it can wait until 2027. I think there are other things that probably haven't been looked at within this report. And it's a good report because it's identifying that we have a massive issue with obesity, but really not giving a plan or a way forward. And I don't think just the fact that we haven't had many applications means that this shouldn't happen, because it's, you know, we don't want even an additional one. And by 2027, how many more will there be? And I just think we need to look into a little bit more, look at different avenues, and the tuck-in thing, you know, it's good, it sounds good, but realistically you have to opt into that. How many people are going to opt into it? Is it really going to make a significant difference? I know that can help with all the current places that we've got already, and it can be used for future planning stuff, and I know, but I just don't think it's enough. And yeah, it's just a comment really, not a question. Thanks.
Yeah, can I just follow up on that? If we're talking about the low number of applications, and if an application came in tomorrow for a hot food takeaway within a short distance of a school entrance, are you saying that the planning regulations, your planning policies as they stand now, would enable you to stop that takeaway being established?
Yes, thank you for that question. It really depends on the circumstances of where that's going to be, and in relation to everything else around it, because it's a planning assessment where you consider things like proximity of school, proximity of other hot food takeaways already in the area, obesity levels in that ward. We can drill down to that kind of information now. By and large, we've resisted these applications, and we've been largely successful on appeal. And it's not, you know, we've had one application last year. The year before that, we didn't have any. And the year before that, we had 3. So we're not talking about lots of applications that are sort of coming in, trying to transform the town. I think the main problem is the takeaways, or the hot food takeaways that already exist. And, you know, I'm sure that there could be solutions around that. Councillor Hussain mentioned licensing. Something I thought of, what, you know, in preparation for this, is maybe we could look at business rates. So, you know, if we looked at a scheme where we provide a reduction for having healthy menus, and incentivize them by having a reduction in business rates. These are things that we could explore and look at to try and tackle the existing situation, which is, I think, what's concerning everyone, rather than, you know, a flood of new applications or new eateries that might come through the door. It's, you know, the evidence is that there isn't that many of them. And even the authorities that already have a policy on hot food takeaways, there's no evidence that it's made any difference, because you have the right of appeal. And I think it's Newcastle City Council who have a policy, and we've looked into that. And their success on appeal is no different from ours, and we don't have a policy. So maybe there's, you know, other thinking that we could be doing to try and tackle some of this.
Okay, I think Councillor Hussain, yes, go ahead.
I think, Chair, you know, this is what we members are asking for, is for us to really, in light of what in terms of the obesity among our young people, we need to look at anything we can do to reduce that, be that in terms of the quality of food, all those initiatives we can get together and do that. This is what members' priority is. This is what we're asking, is that we look for all, through public health, through planning, through environment, through licensing, and get as a one council so that we can reduce that obesity and healthy food for young people. All these things could be done, and you know, this is what we're asking for. Until we get our planning policy sorted, and as my colleague said, Councillor Ali, is that we can't wait till 2027. Situation is really at alarming rate now. Another 4 or 5 years, it'll get worse.
Okay, so I think we can conclude by, I mean, we should, I think the feeling of this meeting is that we should be exploring all possibilities in the planning system, and not just, I mean, we're saying that this is an important part of it, but it's obviously, we're looking at the whole system, the whole planning system, and the whole obesity strategy here. And this is obviously an important part of it, and we should be trying to be doing something to with the planning. And third recommendation is to consider which other key partners should be included in this discussion. And as mentioned, we should be involving public health, licensing, environmental health, and all of the partners in this discussion. And we should, I think, we should be continuing to get the evidence and to use the planning system where we can to help in this in the fight against obesity. Is there anything else? Councillor Ambia.
Thank you, Chair. I think I like your comments regarding, you know, to increase any business rate to discourage business owner to look into this, you know, fast food shop. Maybe it is another way, but you have to be careful. Like depends on this. Some areas there is a high number of fast food, especially few areas like Biscuit Town Centre. But comparatively other areas in north of Luton, the proportion is very low. So to increase the business rate, it will affect, you know, across the business on all of the town. So maybe it will be, you have to be careful to increase the business rate, because it may affect new business, which maybe there's a demand in, you know, Sandon or Birmingham, where there's needs for fast food. So it is, maybe it's not a maybe it's a temporary solution, but it's not a long-term solution to control. And also you have mentioned about obesity. Is from my experience, is a fast food, it's not only obesity, it's changing their people's habits. not only obesity, maybe in less obesity, but these people's food eating habit could change. So we shouldn't look into obesity rate. We should look about how, in terms of which particular ward, how many. And I can see I'm a bit surprised. I can give you one example in Biscuit Road. There are like 5-6 hot food within few hundred years, and Denby school just next to opposite. I'm not sure how they get away and get a permission. And some of the hot food, they turn the premises house into hot food facility. Is there anything you can look into it? Okay, they shouldn't turn the house to make it a hot food, because I have seen a lot of business they turn residential house to hot food. Maybe you can make more restriction what type of property they convert to hot food and proximity to each other business, because I can see there are a few or fast food shop, they are located within few hundred years. Okay, thank you.
Councillor Ali.
So just when you're looking into it, can we look a little bit about the classification as well? Because even in my ward, it says there's 10 hot food takeaways, and I feel personally that there are more than 10 places in Hightown that count as a takeaway. I think the classifications are skewing the figures a little bit. But yeah, I think your ideas are good, and I hope we can come back and have a look at those things. And the other thing is what you were saying about the different wards, a couple of the wards that have the lower number of takeaways are more have less inequality, if that makes sense. What's the word? The more affluent wards basically have lower numbers. So clearly there is a correlation. Yeah, thanks.
Nothing else. We'll wrap that one up. Thank you very much. Thank you. Okay, last item on the agenda, draft work programme. As I've already mentioned, had discussions about the future work programme, about for one thing, avoiding what's happened tonight, having 6 or 7 reports coming to one meeting. So we'll be, in future, we'll be trying to rationalise the work programme. Sorry?
It down a bit.
We will be looking into that, yes. Okay.
Yeah. Thank you.
Okay, and we will be we'll be coming back with that revised work programme. Okay, thank you very much, everyone. Thank you. Oh, and we will be feeding back about the